Can you hear me okay out of this one as well? Okay. One thing I just wanted to mention before I forget to do it, it's a Guide to a Healthy Birth is out. It's a free publication and it's a great publication that we have out on the table there. So I would just encourage you to take a look at that. Please feel free to take it with you. It gives a lot of good additional information. So I'm going to just jump right into it because I know we're all excited. I'm really excited to hear your questions. And every time I watch birth, I get really excited. I'm going to ask the first question actually because I'm curious. Before I introduce everyone, do you guys all still cry at births? Yeah. So yeah, I'm like the one in the room, and mom and dad are doing great, and they're kind of maybe sobbing, and I'm like bawling. It's awesome. All right, so let me just run through and give a quick introduction of everybody, so you have an idea of who all is here. And I just have to say these are all incredibly wonderful and amazing women. I'm not sure how to fix that. So let me get everyone in order. So if I'm saying it correctly, Andrea, right, and Hendrik? No, and Hendrik. Okay, I just have it spelled completely wrong. I have heard the most amazing things about Andrea, but actually this is my first chance to meet her, so I'm super excited to have you here. She grew up in Sandpoint, where, interestingly, the first certified nurse midwife in Idaho was from. After completing her undergraduate program at LCSE in Lewiston in 1989, she began her nursing career at St. Joseph Regional Medical Center. Once she observed her first birth, she knew there was something very powerful and amazing about her. Thoughts of becoming a nurse midwife began to brew, and over the past 22 years, which I'm not sure you're older than 25, so that amazes me. Okay, this can't be a record. Which is wonderful. The birth keeps you young, see. She developed a sense of what women need during labor. And as soon as she felt her 2 children and husband were able to handle her going back to school, she applied to Frontier School of Midwifery and Family Nursing. After completing the program, one has a master's in nursing and is called a Certified Nurse Midwife, or CNM. During the program, Andrea completed a 4-month internship at Deaconess Medical Center in Spokane, where there have been nurse midwives for the past 20 years. Nurse midwives, to explain, because we have kind of a concept, we sort of know where physicians lay and we know where home birth midwives are, but I think it's still not as familiar to many what the nurse midwife role is. Nurse midwives care for women throughout their lifespan, during pregnancy, birth, postpartum, and through menopause. About 95% of nurse midwives catch babies in the hospital. The others practice in birth centers or homes. Midwife means with woman, and in her practice, Andrea believes that for women who want it, continuous labor support is what women need to achieve the birth they desire. When she can, she stays with women to provide this in the hospital, and she encourages doula support as well. Andrea strives to educate her patients in their healthcare options and make hospital birth a mother-friendly experience for patients and their families. So I'm going to read through everybody, and then we're going to get everyone's responses to the film first, and then we'll just open it up to all your questions. So Vivianne Fisher and I have worked together through time, and I think she's incredible. She's been a birth doula since 2007 and is a member of the Police Doula Association, certified by 2Birth and Doulas of North America. A birth doula is someone who provides physical, emotional, and informational support during pregnancy, labor, and in the postpartum period. Vivianne was born at home with a midwife in the late 70s. She grew up in the Coeur d'Alene area, surrounded by many women who trusted the birth process and gave birth at home with professional midwives. She moved to Pullman in 2000 and received her bachelor's and master's at WSU in the Human Development Department. Her research focus was on teen parenting and attachment. She had 3 very different birth experiences with her sons. One born at home, one born in the hospital with no interventions or medication, and one induced with Pitocin and an epidural. Through her journey in pregnancy and birth, she realized the value of a woman educating herself so she can choose what is right for her, releasing fears and the importance of this one day in a woman's life. In addition to being a doula, she teaches in the Human Development Department at WSU, is certified to teach bringing baby home couples workshops, and as we mentioned, is one of our wonderful UMA Center board members. See who's sitting down there next. Now Jamie, everybody up here is wonderful, So Jamie, we just got to meet recently, and it's just, you know, people come in and give you these nice sparks, and she was one of those people. So Jamie is a wife, mother, community member, and full scope family physician. Her profession allows her to take care of patients of all ages through all facets of life, from the womb through the generations. She has been fellowed by the American Academy of Family Doctors, which I was going to ask you, but I don't know what that means to be fellowed. So maybe when we go through, you can tell me what that is. Okay. Lose my spot there. And is the past chair of Pullman's Regional OB-PEDS Committee. She's also a clinical professor at the University of Idaho. Being a delivering physician who also cares for the newborn and gives her a family-centered perspective. Dr. Bowman has been in our community for almost 7 years now. Her husband is a fellow physician, and they are raising their 2 children here in Moscow. Jamie has a passion for human rights, education, the environment, and very importantly, gardening. And then we have Amanda Boswell, who is the local leader for the ICANN chapter. And ICANN is the International Cesarean Awareness Network. Have I said it correctly? Okay. So supporting VBACs and giving information about VBACs and the option of having a vaginal birth after cesarean. She is also a breastfeeding peer counselor with the Whitman County WIC office. She is a mom of 4 beautiful children, and they're super cuties and running around with tons of energy. And like all the women up here, I don't know how she does it and manages all of this. She's an incredible woman too. With various birth experiences. So her first one was an induced vaginal birth. The second was a preterm delivery that turned into a cesarean for failure to progress. Third was an attempted hospital VBAC, again, vaginal birth after C-section, which turned into a CBAC, which is a C-section birth after C-section. The fourth was an empowering and freeing, and I love this, HBA2C, which until she wrote it out for me, I was like, wow, that's like a huge anachronism. So having birth after 2 C-sections. She has a passion for helping women know of their birth options and helping empower them to achieve the birth experience they desire to have, and is an UMA Center board member, and I've just been really excited to have her as a part of everything and getting to know her over this last, I guess it's been maybe a couple months now. Awesome. And then we have Nancy Drasden, who was actually my midwife for a while, and I was very excited. She is a certified professional midwife, a licensed midwife in Idaho. She has been working with mothers and babies since she became a childbirth educator and doula in 1991, and in 1999 she began her midwifery practice. In addition to midwifery, Nancy practices yoga and teaches prenatal yoga. She's a certified lactation counselor, which she's actually hosting classes on this topic at the UMA Center on the first Tuesday of every month. So these are great classes to take advantage of. And to top it all off, she's an advanced EMT. She has 3 children of her own, all born under the care of midwives. So I'm going to open it up to these women so you can hear what they have to say and share their wisdom and hear your wisdom and questions. So, you guys can I want to know what everyone kind of thought of the movie or how it pertains to what you're doing. Just initial response.
I don't know what to do. I guess what I like about the film was that these women really get birth and embraced it. And we're very candid about how they explain things. And I think that we see this a lot just as providers. And everybody has their own birth story, but to them, I mean, they were very passionate about it, and I just really appreciated that. And, you know, that they're doing some things that aren't really totally accepted. Like having home birth sometimes isn't totally accepted for people that are movie stars. So they kind of went out of their comfort level and did something that they really wanted to do, and they accomplished it. And I think that, you know, it's empowering. I like to see that.
I like the film because it's so candid and not just women in this zen like state, like so many of our other birth films that promote natural birth, which is great. But I think also there's the realism aspect of it. The other piece I liked about it was the journey through birth that it focused on. I really think of birth as this journey that you take with your body, and I think we're incredibly lucky as women to be able to have that opportunity to take that journey and to, push our bodies to a place where we don't often get to go otherwise. And so I liked that piece of it too. Yeah.
I really enjoyed the first business of being born and read the book Born in the USA, as Tara had suggested, which has been a great read from my perspective, being an MD and having more traditional training around birth experience. I was thrilled to see women who had high-profile careers, who made a living out of acting and modeling and these other sort of feminine worlds, sit down and become a woman and explain to us their journey through birth, frankly and openly. And I loved that no matter whether she reached the original goal and her birth plan, or if it deviated, they were all still thrilled and happy and empowered and comforted in the end. There's a lot of different ways to have the birth experience that you want, and I appreciated that none of them were angry, nobody was frustrated. In the end, they were happy and they embraced what they experienced, and that was something I really enjoyed seeing.
I agree with Jamie in that they didn't feel the frustration, and that they were given options as to what they could have, and that they also felt the strength to make the decision they felt was best for them and their baby, even if the doctor necessarily didn't feel that that's what they should do, but also that they were able to come to terms with the birth that they had, whether it was exactly what they wanted or not. And they had the support people there to help them come to terms with that birth. Because there are many moms that have a birth kind of just placed on them, chosen for them, how they're going to deliver, and they don't have that opportunity to really deal with it. And all these women kind of did, and just being able to talk through it really helps for some women to deal with the birth that they have.
What I think I like best about the movie is how empowered all the women felt after their experience. And that's really important to me as a midwife, that women come through birth feeling empowered and strong as mothers. And I think that having an empowering experience makes strong, healthy moms and strong, healthy families. That's really important. I also felt like women really appreciated their bodies, and we've gone through a lot of our lives hating our bodies. And it's nice to see them really value what their bodies did.
So if anyone would like to come up and ask questions, obviously it doesn't have to pertain to the film. So anything, in all my years doing this on various levels, it's rare to get this many incredible people from this diverse a background in one room to have this kind of discussion. So please feel free to ask any question you have of the practitioners here, any questions you have maybe about your own birth coming up, practices that are in place here for home births, or the nurse midwifery births that are offered down in Lewiston for the hospital-based births that are here. Anything you can think to ask or just want to know. And if you raise your hand because you don't want to come up here, I'll come see you.
Hi, I've never been pregnant. I'm not expecting either. I just am really curious. I've heard a long committee about eating placenta after birth, and I was just curious what you thought some of its benefits were, or effects, or how you all thought about it.
Tara might be able to best answer that question.
I'm not on the panel. I'll let you answer. I think it's fabulous, quite honestly, and offer that service and encapsulated my own. Actually, my husband did it for me. He was a wonderful placenta dehydrator and encapsulator. So I would like to open that up a little further to you guys, but personally, I do think it's incredibly valuable for postpartum recovery and support. And with Davina, who has been the person here, amazing doula, processing placentas for this last several years now. You know, she says it's just your perfect hormonal balance. It's so specific to you. Yeah.
When you say processing,
Oh, essentially there's two methods. You can either steam or you can do it raw, and then you're dehydrating the placenta and then grinding and encapsulating. And, you know, okay, I will take an extra minute on that. We tend to think that we're getting all these resources back into our bodies after pregnancy, and I can say after 3 kids, I'm still, you know, depleted. That I was really happy to have the placenta encapsulation post-pregnancy, and I'm still back to taking iron supplements and the rest of it, because it is an incredible process to go through pregnancy, birth, and then, you know, say a year or more of lactation is a huge demand on the body. So we tend to think we're going to get that back with our poor food supply and the, you know, lack of minerals that's in the earth, and it doesn't happen. So whatever you do, whatever you decide best to do postpartum, it's taking care of yourself and getting that nourishment back in.
In a hospital setting, frequently the placenta is kept for a while to make sure everyone is healthy and doing good, but in the end it's your placenta. You get to take it home if you want to, and there is some emerging evidence that demonstrates that consuming the placenta, usually it's slowly at the postpartum period, and you can utilize those encapsulations for years afterwards. It replenishes iron stores and hormones. But I also have a large number of women who've saved encapsulations and are using them now during menopause and helping with menopausal symptoms as well. And it's your own body tissue, so there's very little harm or risk associated with the process.
My doula, when I had my home birth with my last one last February, had not said anything during my pregnancy, and after I had the baby, she's going to leave. She's like, "So you're going to consume your placenta?" I said, "Do you want me to do it?" And she said that yeah, she had actually ingested hers raw. It helped with the bleeding and stuff. I said, "Well, I don't know that I can do that. I was planning to keep my placenta anyway so that I could bury it and plant a tree." So we had put mine in the freezer, and I was like, "Well, I'll do a little research on this." So I started spending some time researching about eating your placenta, and found out about the encapsulation. So my birthday was coming up, so my husband bought me a dehydrator, and I encapsulated my own, and it was wonderful. I wish I'd done it with my other ones. My doula had kind of said, it's like, "Oh, it's like your happy pills." And it really was. I was having, with those postpartum days, you have those mood swings that are all over the place, and I'd be starting to have a really bad day, and I'd just go get one of the pills out of my fridge, and within a couple of hours, it was a world of difference. So it's something to definitely look into. Whether a person chooses to do it or not is completely up to them, but it's definitely worthwhile looking into.
As a caveat too, it's really strong when you add it to your porridge, like my husband did for me. We're not really accustomed to eating such strong things. So the encapsulation works really well.
I'll come back to you, Lucy. We'll get your question.
I just wanted to add to that a little bit because I am expecting, and it is our plan to have that encapsulation process. After our first son was born, I developed Hashimoto's, and so emotionally just up, down. I thought I was going insane. I was having self-destructive thoughts. I didn't know what was going on. And it's just the research that I've done so far is giving me a lot of confidence to do this. So I love hearing this work. Thank you.
What are the options out there for women that do have cesarean birth? Are they able to encapsulate their placentas, and how do they go about doing that? You know, especially if they aren't planning a cesarean.
They are able to, but you have to remember to tell them not to put formaldehyde on the placenta, which happened to me at one birth. So if they know and they're being mindful of it and everything is okay and they're okay with releasing it based on why she had the C-section, then it should be fine. Did you have something to add?
I think a lot of people have this belief that it belongs to the hospital or it belongs to the doctor. It's your tissue and you have every right to it. sometimes if there's worries about baby or about mom's health and more tests need to be run, like we can do cultures and genetic tests off placental tissue, then we might need to hold a portion of it or all of it for 7 days, but after that point in time, it's yours. And yeah, just make sure it's in your birth plan, that you talk to your providers ahead of time and that they know. Hopefully, formaldehyde only goes on the placenta if there's really something bad going on. So usually that won't be part of the regular processing of the placenta unless there's an issue, but letting them know ahead of time helps us fulfill that birth plan.
I heard you had to get a doctor's order in order for that to be okay, I guess.
Technically, to release it, you need the physician to release it to you, which is kind of just the process of the bureaucracy of a hospital. But if you put it in your birth plan, we can make it happen for you.
You guys have any other questions? Yes.
I'm just curious as to what a woman should expect to pay for each type of birth or each of your services, and also if you find that insurance companies are likely to pay for your services.
I suspect that, except for the doulas, I probably have the lowest cost service overall. If you plan a home birth with a midwife and you have the baby at home, for me the flat rate is $2,000 for the prenatal care, birth, and postpartum care. There are a few extras in there, and lab fees and ultrasounds aren't included. Insurance occasionally covers me. More and more it does, and pretty soon, assuming I filled out my paperwork correctly, Medicaid will cover me as well in a few weeks here, and I will. So I think that answers all of those questions.
In physicianhood medicine, we have this set of rules called Stark laws, which basically are anti-kickback. I have no idea what my charges are. They don't tell me, so that I don't inflate my charges artificially. I do have a fun story, though, about hospital charges. With my second delivery, I went ahead and paid ahead at Pullman Regional Hospital. I get my 10% reduction by paying cash, blah, blah, blah. And I ended up with a really exciting delivery situation where my husband, who's a physician but not trained nor licensed to do deliveries, was the only one there at the hospital to catch Evan. And so he did my delivery, which was awesome and fun and a great story in and of itself for those hypnobirths. They do work. They are not full of shit. I got a check back from the hospital in the mail, which I just turned around and donated back to them and said, give it to the foundation or something. But it's not the way that I would suggest you cut your costs with your delivery. But I was pleasantly surprised to find out that he couldn't bill for his services, which was great. He did a good job, though. He was a great attendant.
So doulas charge around the country anywhere from like $300 to $2,500, and with around the PLUS, if you have a doula, they're likely to charge different rates. The PLUS Doula Association all charges the same rate. We charge $550, and that includes 2 prenatal meetings, the birth, however long that takes, and then at least 1 postpartum meeting.
And I kind of have an idea how much I bill for. I don't really ask a lot of stuff like that. But insurances are now starting to reimburse nurse midwives at 100% of what physicians bill for.
Does that give you a good perspective? Okay. And does anyone have a good sense of, as far as looking for that data, maybe the place to recommend?
Call the office. Call the office and ask them what the charges are.
And your insurance, yeah, I mean, unfortunately, everything is very variable. And as a Canadian now living in the U.S. over the last 10 years, You know, I'm kind of used to the fact that we pay our taxes and we get health care. I like that system. So it's very variable. So if you need, when you need to know, you need to get things written down. Having worked years at the hospital, getting things written down makes a big difference. And it does legally need to be transparent.
Can you talk about some of the options for women that have had a C-section before? What their other options might be?
It depends on kind of who you talk to. Again, as Tara was talking at the beginning, for a woman that has had a vaginal birth, unless they've had a vertical incision, it's less likely to have a vaginal birth after the C-section, just because the chance of a rupture is greater with the vertical. Whereas most of them are doing the horizontal, like bikini cut. The chance of a uterine rupture is 0.02% for a woman that has had a C-section. And of that 0.02%, the chance of it being a catastrophic rupture is 0.02%. So for most women, depending on how your incision was and your circumstances for your cesarean, most women are able to have a vaginal birth. It's finding a physician or a midwife that would take you on to provide care for you. In this area, there's various degrees as to whether doctors or the midwives can. I know Nancy and Andrea can talk about the laws in Idaho for doing vaginal birth after C-section. So just kind of talking with the doctors, see if they'd be willing to do at least a trial of labor for a vaginal birth. Actually, the AGOG has, within the last couple of years, has actually recommended for women that have had a previous C-section to at least give them a trial of labor for a vaginal birth. Whether that ends in a vaginal birth or not, it depends on how the labor goes.
Just briefly, in Idaho, licensed midwives are allowed to accept clients who have had one previous C-section with a low horizontal incision, and not the subsequent vaginal delivery needs to be more than 18 months after the cesarean.
And in my practice, I don't do VBACs because the physicians I work with do not do VBACs. And part of the reason is because their insurance does not cover them to do so. But can I add this? That just because you have a C-section does not mean that you can't do skin to skin and have your baby there, present with you, breastfeed right on the table. I just feel like that's a shame that more women are demanding that time with the baby directly after birth. We initiate that not only with our batch deliveries, but also with our cesareans too. So that's part of the reason I think why I get a lot of patients who are a previous C-section. So I take care of them prenatally and then go in and assist with their surgery, make sure that all this happens the way they want it to happen. And I think it does depend a little bit on who is the nursery nurse that day. But for the most part, you know, that's pretty much a standard that we are trying to kind of uphold that in the whole baby-friendly initiative too, so that moms and babies can stay together.
Trial of labor after cesarean at Pullman Regional has been a tough conversation, and there's just been some recent changes that are in the works. One of the challenges is that we know statistically that there's good information that says a vaginal birth after cesarean is safer than another cesarean. Sometimes that's not feasible, and at Pullman we try really hard to accommodate what we call our natural C-section, which means we lower the drape, we allow mom and dad to tell us what the sex of the baby is rather than us tell them, and then we initiate skin to skin as quickly as we can if the infant is stable and doing well. And likewise breastfeeding quickly as possible in the recovery area. For women who are good candidates for a trial of labor, the standard of care and standard of care in medicine is sort of this fuzzy gray area where we say everybody's doing it this way, so we should all do it this way so that nobody's doing it differently and no one can get any kind of lawsuit brought upon them. So a lot of the decisions are made to avoid litigation, which is a terrible way to practice medicine, but the reality. The standard of care in the hospital setting is that you have your OR crew there, you have your surgeon there, and you have everybody ready in case that 0.2% catastrophe occurs. We don't do that for vaginal deliveries, and there's a higher rate of potential catastrophe there, but it's the standard of care. Challenges for small community hospitals like ours, where our VBAC success rate, meaning successfully delivering vaginal after prior C-section, was less than 50% at Pullman. It meant a lot of resources being utilized and the outcome still being a C-section. And that drains our hospital's resources, and for that reason, there's been a shift towards not offering vaginal birth after cesarean. And that raises a whole other set of questions. What if women come in, they've been contracting at home? I had an hour-and-a-half long labor with my second baby. There's no way that if I had waited till contractions kicked in that I would have made it in time for cesarean. You know, those scenarios, you're gonna have women walking in who say, don't cut me. I'm already here, let's just do this. And so we've been trying to troubleshoot around those scenarios as well as how do we empower those women with that type of decision. It's a tough situation because we have a different type of setting here without the same resources as a university setting where I trained, where we had 24/7 OR open anytime. That at the same time tempers the decision to go to C-section in the first place, but it also makes supporting women through a trial of labor a little bit more challenging and difficult.
So just to add a little piece to that, on May 3rd, we're going to do a lecture series with people specific to VBACs and options in town and discussing through the statistics and some other elements of it. So the police doulas and the ICANN group of the police are going to host that. It is a huge discussion, and you know, it's over the years, it is fluctuating through a variety of things. There's a lot, if you want to know about it, there is a lot to know about it and a lot you need to know in order to make your decisions. So I would encourage you probably to come out to that. Stacey, if you want to come out to that one, that'd be great. Well, while you're thinking of questions, I might I'm not sure how to phrase this as a question. I'm better at rambling than like succinctly giving a question. So, but one thing, yeah, Nancy's like, that's how my labors go too. No. So one thing I really enjoyed, labor is a lot like we are. If you haven't figured that out, it kind of reflects who you are as a person. When we were viewing the film and going over everything, one thing that came up I thought was really interesting and nice to be able to speak about is how varieties of practitioners come from, these varieties of backgrounds and beliefs, and that part of choosing your practitioner can be to both understand who you are as a woman and what you need and who this practitioner is, and feel that, you know, you either, this is a right fit or it's not at all the right fit, but that you have the ability to go and find that right fit. So I wonder if you wanted to speak any more to that?
Well, you summarized it pretty well, Tara. You know, if you're having a conversation with your caregiver and you're feeling like you have to push really hard to get what you want, it's probably a good idea to talk to some other caregivers before you make a final decision. So, you know, if you're somebody who, I'm trying to think of an example that's not a VBAC, you know, but that's a good one, I guess. If you're somebody who really wants to have a vaginal birth and you're hearing from the person you're talking to, your potential caregiver, that it's not going to be an option, you're going to be hitting your head against the wall. It's not going to be an option. And so I think you want to know what your choices are. You want to know what you want for your birth experience, and you want to find somebody who truly supports those options. And that may be a planned elective cesarean before labor, or it may be a water birth at home. or somewhere in between.
I know what you want. Don't be afraid to talk to your provider. If you're afraid to talk to your provider and tell them what you want, then that's probably not a good fit. And if any time during your pregnancy you start to clash on this is what I would really like, and the doctor's like, well, I just can't give you that. Don't be afraid to break up with your doctor. If it doesn't work, it doesn't work. Find somebody or a midwife, whoever, a provider that will give you the opportunity to have the kind of birth that you want.
I know my style as a provider changed a lot when I became a mom. Realism started to kick in for me, and I had a better understanding that there's a lot of great ways to be a parent and a lot of amazing ways to give birth, and so flexibility became important. Just as valuable as it is for you to feel a connection and a fit with your provider, we as providers want to feel a connection and a fit with our patient. If you're feeling static, I'm probably feeling static too, and I'm thinking, oh, they don't trust me. When bad things could happen because they're not going to be honest with me, and I'm going to be transparent. Most important thing for me as a provider is to know that we're going to communicate, and that I can trust that you're going to give me all the information, and likewise, you're going to trust that I'm going to honor your needs and your wishes during the process. And so if it doesn't feel right to you, it probably doesn't feel right to me, and it's way more ethical for you to fire me than for me to fire you, so do me the favor. But that being said, though, I know each one of us has the stuff that we love to do and enjoy doing. Over and over again, as I've watched more of these movies and researched more and read more books, agree completely with the opening statements that Tara made, that for a low-risk woman, her safest, most reasonable option is midwife. And in a way that makes me sad, because I really love you low-risk, healthy women who want natural births, because it's fun, and I like it. But I am happy to honor other complications and work through that too. I try to think about not passing judgment when I hear birth plans. And the only birth plan that I'm still have to be completely frank and honest and transparent, kind of turns my stomach, is when I have women who don't want to labor at all. Plan my C-section, I don't want to labor, I don't want to push. And that, for me as a mom, breaks my heart. For me as a doctor, I can say, oh, Kate, I don't have to be up all night, you're not going to call me in when I'm busy with my own kids trying to get them tucked into bed. Sweet. But truthfully, as a mom, I was like, there's something beautiful about that experience. And I suppose that still is a judgment, and that's the piece that I have to work on.
I would just add on to that. I think it's very important that people understand the roles of the different people in the room, and they understand, what a nurse's role is in the process, what the doctor's role is in the process, and when do they see the doctor, and things like that, and what is a midwife's role if you're doing a home birth throughout the process, and what is a doula's role. And they have a very clear understanding, because I hear so often, I didn't know, I didn't realize, that X, Y, or Z. I thought the nurse would do all of these things that a doula actually does. So I think that's another piece of that.
And I should reiterate that whole thing too about knowing who you are, because I walked into a room and the patient was just about, I think I got called, it wasn't my patient, but so I hadn't been in there for very long, maybe an hour or something, because I usually do come in while people are pushing. I don't just show up for the head to come out. No offense for people who do. And the dad says, oh, I didn't know you were gonna catch the baby. So I should have said, and lots of people are confused about some of those roles, but anyway. I think for me, listening to people is a really important part of what I do, and developing that relationship with them, making sure I know exactly what they want. I usually explain explain to people too, just on our first visit, we do a lot of little meet and greets where they come in and talk to you about, you know, if they want you to be their provider, which I feel is a really good thing. I think some providers get a little, well, why can't you just come to me? Why do you have to talk to me? Which I'm like happy to sit down and talk with people. It's kind of fun. But anyway, so I think listening is probably one of the most time-consuming but worthwhile part of my job. Do a lot of talking to, but.
Thank you. Yes.
Maybe can you explain more the difference between what you do as a nurse midwife versus what the physician does?
What the physician does?
Will you just reiterate that question?
Oh, she asked what's the difference between what a physician does and what I do. Well, I usually take a little more time with my clients. If I have somebody who's really anxious, I'll see them way more visits than they would see a physician normally. Then when it comes to laboring, they come to the hospital, they get checked, they call me. If they want me to come into the hospital at the time, then I just come in and I do labor support. Until they have the baby, as long as I'm not in the office, which actually has happened pretty well. I think women give birth when they feel safe, even if it's at the hospital, and so they know. And I've had a couple people wait, like I haven't gone anywhere for a year, and I went to Seattle for the weekend, came back, and I checked a patient on Tuesday morning. She said, I felt really crappy this weekend, but I told them I wasn't going to have my baby till you came back. And she was 7, in the office, walking around. I'm like, okay, I'll check you, let's strip your membranes a little bit, and go walk around at Walmart for an hour, and I'll meet you over there in a little while. So as far as, you know, afterwards too, I was a lactation specialist as a nurse, so I do help people with breastfeeding after the birth. So just in general, a little more time, more visits. I feel like it's a little more personal type of care. In some respects, it depends on the physician. This physician sounds really personable. The physician that I work with, Dr. Bixby, she's really personable as well. So I think it just depends. Sometimes really smart people who are really good practitioners don't relate well to people. So yeah, there's a difference there.
And then I'll take it as a compliment to be more personable and less smart.
No.
No, I didn't mean it like that. No, I like it. I have to admit that I am proud to not be the typical physician. And that's probably why I self-selected into this group of individuals. My training was mostly by certified nurse midwives, I have to admit. So while I have other demands on my schedule that do create a barrier for me being there for labor support, I love pushing with patients. I love the opportunity to do home visits on my newborns, which I can do over in the state of Washington. And I think the big difference for me in the grand spectrum, because it's a kind of a gray area as you go from provider to provider, is I don't have cesarean privileges. I can't cut by myself, which I'm thankful for. It tempers my ability to make that kind of a choice for a family or lead them down that type of a road. But I'm limited to only delivering within the hospital at Pullman Regional.
And I only catch babies at the hospital as well.
Do you want to know a little more about everybody's roles, just to have a little more specific?
Well, we wanted to hear Jamie answer the question about the fellowship.
That's right.
Sounds very fancy.
It is very fancy. So each of our academies, and I belong to the Family Medicine Academy, you've heard ACOG thrown around a couple of times, which is the American College of Obstetricians and Gynecologists. By the way, they've shunned me because I'm not a gynecologist. I am a family doctor. Well, each of our organizations has additional credentialing that they will award you if you've met certain criteria. And so because of all the bazillion different things that I do in a regular day, I got the extra initials, and they feel nice to have behind my name. They're going to be most valuable within my teaching roles, and so as a clinical professor, that's where that comes into play most often.
Thank you. Yes.
So, as providers, like when you guys choose
usually wait until it stops pulsating. The baby's still getting blood, oxygen, nutrients through the cord, so there's been some benefit shown to that.
I leave it up to the parent's birth plan. If you want me to wait until we cut the cord until it stops pulsing, I can do that for you. I usually will hold baby at the same level as the placenta so we don't end up with transfusion in the wrong direction. Babies can end up anemic occasionally if you wait to clamp the cord. And I know I feel a little odd because I get to hold the baby during that time and say, ooh, look how cute they are. And I really am thrilled to put baby up on a mom's chest. So it's up to the parent and their birth plan as to what I do. That's one of those things you have a choice over.
My practice is, unless there are some unusual and extenuating circumstances, I wait until the cord stops pulsating to clamp and cut it.
Would you guys like to just maybe give a little brief overview of the benefits, either way, or maybe circumstances? So do you want to give an overview of the benefits?
You know, I hardly ever cut the cord on the perineum anymore. If it's tighter on the baby's neck, I try to somersault the baby and unwrap the cord and leave it intact because baby's still receiving oxygen through the cord. If I have to resuscitate the baby, I prefer to keep the cord intact because what I'll do is I'll bring my little warm tray next to mom and put the baby on it right next to her so if the cord's long enough, it'll reach. And that cord's still pulsating, and it's pulsating at about 70% saturation, which is better than none. And I'll go ahead and do whatever I need to do for the baby while the cord's still intact. So it's been a long time since I've cut a cord before it stopped pulsating. I did a shot of Pitocin into the cord. I think I did that to get the placenta. I think we had a little partial detachment and a bleed, and I had to get the placenta out fast. So I think that's the last time I did it, probably 9 or 10 months ago or something.
If I'm really surprised at what the baby looks like when it comes out, it's only happened a couple times. It just looks like a wet noodle. It's white and pasty. That's usually when I cut the cord. Nurses get a little bit, well, I get nervous too. It needs oxygen and maybe resuscitation, so usually they do take it to the warmer momentarily. And then once it's stable, give it back to the mom. But that's the only time I do it.
I'll do it if you want me to.
I was wondering if you guys could explain some of the new midwife laws in Idaho and discuss
So the direct entry midwife laws.
Yeah.
Okay, in Idaho, prior to 2010, there was no specific legislation regarding the practice of midwifery in Idaho. In July of 2010, a law went into effect that required essentially all midwives to be certified professional midwives first, to take additional training in suturing, in shock and IV therapy, and in pharmacology, and to, once that was completed, to obtain a license from the state. We have a pretty good licensing law. Some of the big changes that have affected us are, frankly, one, the cost of maintaining the license. It's expensive compared to other licenses for similar level practitioners. And so there are some women who are risked out from home births who we might have felt safe taking before. We can't do multiples at home. We can't do breaches at home. And there are midwives in the state who have good training and experience with breaches and multiples and can't take those clients anymore. We have like certain restrictions on body mass index. But some of the stuff that we can do now, we couldn't do before, and we get to keep those women in the practice. So for instance, if somebody is positive for group B strep, she doesn't have to go to the hospital to get antibiotics. I can give them to her if she wants them. And so that's, you know, there are pros and cons. And mostly, though, in my experience, it's been more positive than negative. And one of the good things that has come out of being licensed is having, I think, a better and more professional relationship with other providers, and that's really been a good thing. So I think in the long run it's going to be helpful. Did that answer your question? Yes. Okay.
Yeah.
You were talking about kind of births that are at risk at home, and you talked about multiple limb breaches. So personally, I have myasthenia gravis, and I want to do completely natural birth, no cesarean, but I don't know if that's going to be an option for me, especially if the baby can get transient neonatal myasthenia. So I'm kind of wondering what some of you think my options would be outside of the hospital or outside of cesarean.
I actually don't know enough about it to answer that, but there are some underlying medical problems that can be followed by a physician separately from the pregnancy, and as long as the mom remains stable and things are looking good, she can go ahead and have a home birth as long as, you know, so for instance, if I have a mom who's hypo or hyperthyroid and she has an endocrinologist following her throughout the pregnancy, she can stay home and have the baby as long as her numbers have been good throughout and it's been well controlled. Does that kind of answer that? Does someone else want to take it on?
Well, I was going to say that if you have to think about what you want from your birth experience, so that if you end up in a situation where